I'm very grateful to Dr. Das sir for allowing me to speak in his IC. Thank you so much, and we know how much work he has done for oculoplasty and the trauma. So I'm really grateful, Dr. Das. So here I'm going to talk on small incision external DCR. So we all know DCR is really bread and butter for all oculoplastic surgeon, and everybody must know this. And there are many techniques available, conventional DCR, where we're used to put such a large incision. So here I'm going to show you the small incision DCR. In our Drishti Netralaya, out of 5447 lacrimal surgeries, nearly 1205 was canalicular surgeries, and DCRs what we did was 4195, and IND of course for in 47 patients. So conventional external DCR is taught to us in our college time, and still it is a gold standard. I'm not against that, and it's very good surgery. The only thing is cosmetically it gives a very, very large scar. So nowadays patient may not accept, or sometime it comes with the granulation also. Transcanalicular laser DCR is also a wonderful technique where there is no scar. You can have a sharp aiming beam. You can see through the endoscope. You can just puncture, and it's very, I must say, it's very glamorized surgery, and you may have to support it with stent also, because it has got very small opening. The complication sometimes happens when the patient blows the nose post-operatively. There can be emphysema. So it's not a good it's bad complication, and you should take care of that. Endonasal DCR, of course, is very good surgeries. We do endonasal DCR in a hospital, but it needs quite extensive skill also. You have to have thorough understanding of nasal anatomy, and sometime you may have to take support of ENT, which we are not taking in our hospital, but with the passage of time you can learn endonasal surgeries also. Then we developed in our hospital transcanalicular manual DCR. So that was just a simple cannula what we designed. So one fine day I was not able to do anything, and suddenly what happened that after puncturing, after dilatation of lower canaliculus, I just passed a small blunt tip cannula which has got side opening. I just passed through the lower canaliculus, and I just pushed into the lacrimal bone, and you know lacrimal bone is very papery bone, so it opens through the sac. That doesn't mean we have just opened very small hole into the canaliculus, through the canaliculus into the sac. So that worked very well. We did this technique in lot many 729 patient, and we published this also in the Indian International Ophthalmology with this many result. Though it was long-term result, definitely will not be good, because it was simply a simple internal IND, as well as you can even do pre-cataract surgery. So it's very easy, but long-term result, I would say it was not good. So based on this technique, 6 months result was very good, but based on this technique, we just tried intracath Teflon sleeve DCR, where you can just pass the intracath, 22 gauge sharp long intracath you can take. You can pass through the canaliculus, enter into the middle meatus, confirm it through the endoscope. But mind you, the intracath material is not an inert material, because body throws it within 7 to 8 days. So even if you are using intracath material, that Teflon sleeve material of intracath for your canaliculostomy, that also extrudes very fast, because it's not an inert material. So we tried this technique also in 34 patients. Then came a small incision external DCR based on our own experience of transcanalicular manual DCRs. So this the anesthesia is simply infraorbital anesthesia. I am not going into detail of the anesthesia, but technique, if you can understand, just simple dilatation. You can just get this hard stop, hold the cannula in one hand, then you just puncture near the bone where exactly the sac lies. you can just puncture with the cannula. So now you know that the cannula is through the canaliculus, through the sac, it is into the middle meatus. Then again I puncture through the skin. There should be a metal to metal touch, not the soft touch. That means your blade is touching to the cannula, which is already into the middle meatus. Now you can take the perforator. Again the perforator has to touch to your cannula, which should be metal to metal touch, and then you can puncture the lacrimal bone. So you can confirm it also through the nasal endoscope, then supported by silicone intubation. Any of the stent material you can use. Here I don't have any financial interest. We are using this material since long. You can see through the wound, the patency you can confirm. But at the same time, you have to confirm the patency through the lower canaliculus also. This confirmation of the implant with the help of endoscope also we did in A1857 surgeries. And you can see even simple, you don't have to pass the fluid. You put the fluid and it goes. It's very large opening, so it doesn't seal with the silicone tube itself. We measured the wound, and most of our patients' skin wound was less than 5 millimeters. So we name it as a SILS, small incision lacrimal surgeries, because people are now going behind SICS and SIMS. So it's SILS surgery. We used this technique same, even the angular vein was cut. I'll not go into detail of the this video, but even with the presence of angular vein cut, you can just cauterize and you can go ahead with the same technique. It's very easy. You can implant and then you can proceed with this surgery. When there is a common lower canaliculus block associated with NLD block, we can use the Teflon sleeve for temporary purpose, which you can confirm also through the external wound. Post-op, after 1 month, you cannot see any scar, so it's as good as endonasal DCR also. Expected result is in the late stages. It is expected that the presence of tube into the lacrimal bone halts the process of healing of the osteotomy. So you're sure that the osteotomy will not close. It facilitates the migration of sac epithelium around the osteotomy and continues with the nasal mucosa, which all know what the DCR means. And these form a permanent opening with the small incision external DCR. We see this patient day 7, week 7, and then 6 weeks. I usually prefer to use endoscope also in our OPD area, and we see what is there into the nose also. Post-operatively, definitely antibiotics and everything can be done. But sometime there can be causes of constant epiphora. So the reason can be early causes, plugging of the distal end of the silicone tube itself by discharge, mucus plug or blood clot, plugging of the distal end of the tube by nasal mucosa, because nasal mucosa starts healing within 7 days. Late causes can be the tube itself. If you're not put properly into the intracystic place, then that can be a abnormal placement of the tube, that can be extracystic, and there can be sometimes some syndrome, which I'll tell you in this talk also. Nasal endoscopy if you can perform, and sometime we may have to take CT DCG help also. Sometime you have to remove the crust. So as I said, it's just mucus plug which is covering the distal end of your implant. So you remove that and the patient is happy, which is already which can be done even in outpatient department. So out of this are if nasal mucosa is there, you can just use the technique of transcanalicular manual DCR. This name we have given is cannula DCR. Transcystic position of implant, if it is done, their patency on the syringing through the wound intraoperatively will be definitely there, but when you go through the canaliculus, there will be sac contracted. So collapsed sac will be there, and then later on come with the epiphora. Extracystic definitely, because it's not taking cyst in sac in the wall, so there will be a patency intraoperatively, but later on it comes with the constant epiphora. Dislodgement or incomplete placement of implant can happen, and if this dislodgement happen, if the implant comes anteriorly, there can be some syndrome because fluid gets collected under this implant. Sometime extrusion of the tube happens and we remove the tube. So in such 1 or 2 patient, we had to remove the tube after extrusion, and in this kind of patient, then I performed the external conventional DCR, so which is still gold standard, but with a small incision external DCR, we have still 95% success rate. Sometime we may have to take the combination of the techniques. So this external DCR I'm just showing because the tube was explanted. And some of the time when only nasal mucosa is the covering part and blocking the passage, I put bicanalicular intubation through this bigger silicone implant which prevents the nasal mucosa to cover the distal end of the canalicular. Sometimes granula can happen. What is ideal? Laughing patient is an ideal. I am grateful to my teachers, I am grateful to Dr. Das, and I am grateful to all of you for patient listening. Thank you so much.
It is a new one, so there may be intubation, but one thing for everyone is not possible because that you need an endoscope. That's a one of the big problem with us is maximum institute that's a very costly. Endoscope is very costly.
Absolutely.
And that's the another.
So in that case, what right now we are just telling people that if you are not able to spend for endoscope, you can just pass the fiber optic cable through the canaliculus and then look through the nose. You'll get the sharp aiming beam where you can see exactly there the sac lies. Thank you so much.
Dr. Shah, how long you are, if you are using a silicone tube, how long you are keeping it over there?
It's for lifetime.
Okay. Any complications you face like granuloma formations, infections and all?
That's what I showed in my presentation because one patient had a granuloma formation and one patient extrusion because it develops the SAM syndrome. So as we say that Krigler's massage, so sometime adult patient also start moving here and there. They take out the tube from the osteum itself, so it comes anteriorly into the sac and then slowly it comes anteriorly, then extrusion
And while
happens.
putting the cannula, like I feel, how you are doing it? It's like
it's exactly 45 degrees. So when you just passed cannula through the lower canaliculus and move your hand 45 degree, you'll definitely get the lacrimal bone and you can puncture anytime.
You told the metal to metal touch, no?
Yes.
So it's with the punctum dilator you are going to like...
No, cannula is already there in the middle meatus.
Yes.
Now you are cutting.
Yeah.
So that should be metal to metal. That means from skin you are cutting the sac and entering into the sac. From the canaliculus you have entered the sac through the canaliculus.